Dipti, start.
Shall I start?
Yeah.
Hello. Am I audible to everyone? Hello. Am I audible to everyone?
Yeah.
Okay.
Yes.
Good evening, all. You have joined us on this webinar today via Zoom or YouTube. I welcome you all on this second webinar hosted by Mumbai branch of Association of Physiotherapists in collaboration with Arthroscopic Academy of Mumbai. Today is our second webinar under the shoulder rehabilitation out of the 4 webinars that we are going to plan. You can view the information on your screen. Sir, can we show the information? Ravindran sir. Okay, we will share at the end of the webinar. Okay. Now I would like to introduce our today's chairperson, very senior physiotherapist, Dr. Vikas Rajadaksha sir. Sir has served at KM Hospital as a HOD and held various teaching positions in the same college for 14 years. Sir has worked as a rehabilitation consultant with Ministry of Health in Oman. He has worked member of curriculum development for physiotherapists, occupational therapists, speech therapists in Muscat. Sir has also worked as a coordinator for upgrading physiotherapy program in Glasgow, Caledonian University of UK. He was an ex-member of Overseas Physiotherapy Recruitment Committee in Oman. Sir has worked with Mumbai Cricket Association, Bombay Hockey Association, and various sports bodies in Mumbai between 1979 to 1992. List is unending. Currently, Sir is mentoring team of students of KJ Somaiya College of Engineering to develop a physiotherapy tool, a Robo Rehab. Sir, we are lucky to have you with us today. Sir, will you please introduce our speaker today?
First of all, am I seen by everybody? Am I seen by everybody?
Yes, sir.
Yes, sir.
I myself cannot see. Yeah, okay. Now I can see myself. Right. Okay. Good afternoon, everybody. It gives me a great pleasure to be associated with Bombay branch of Indian Association of Physiotherapy once again. And today we have 2 eminent speakers, Professor Dr. John Nyland and Dr. Yuvraj Singh. So first I'll introduce Professor Dr. John Nyland, a very good friend of mine. I've met him several times in Mumbai. He is a professor and program director for Master of Science in Athletic Training at the Spalding University, Louisville, Kentucky, USA. He is an international editorial review board member for various journals in the field of sports physiotherapy. He has either authored or co-authored 190 peer-reviewed papers as well as 35 book chapters. I wish to make a special mention that during 1996 and 2008, he has accompanied United States of America team as an athletic trainer and physiotherapist at the Paralympic Games. Similarly, in 2012 and 2016, he also has been an international para-archery classifier. So over to you, John, without wasting much time. Most welcome to our members.
Thank you very much. Thank you very much for such a kind introduction. Shall I share my screen now?
Yes, sir.
Okay. Oops. Okay, thank you very much. The title of my talk is Restoring Dynamic Shoulder Stability. You know, the shoulder is a unique joint. It's so mobile. I think it's probably the most challenging joint to work with in sports physiotherapy in terms of trying to have a successful patient outcome. And one of the reasons is it's involved in both open chain and closed chain function, particularly with this extreme sports that many of our clients are starting to engage in. These are my disclosures. Dr. Vikas did a nice job, but there's no need to go into that. I'm also president of the board of directors of the Journal of Orthopedic and Sports Physical Therapy. So one of the reasons the shoulder is at such risk is because of the activities that our athletes are now engaging in. You know, it's not enough just to play cricket or soccer or, you know, badminton. There's outdoor activities, adventure activities that many clients are starting to find more fulfilling, more rewarding of all types. And I got involved with this through Omer Maidan, who's a well-known hip surgeon out of Boulder, Colorado, originally out of Israel, and Francesco Ferletti out of Italy, who are both involved in extreme sports. And in extreme sports, the shoulder is at particular risk. And I'll tell you why coming up here. So this is Jeb Corliss. He's a wingsuit flyer. Now, for most of our athletes, if they hurt their shoulder and we don't get them back, they may not have a successful career. But in extreme sports, if they hurt their shoulder and we don't rehabilitate it correctly, they die. They have to be able to have their shoulder to operate things such as their parachute so that they can safely land. And you have to have normal mobility as well as normal strength in the shoulder for this to happen. This is just a general wingsuit flying video. Now in Jeb Corliss's case, he actually had an accident and he had to put this into effect when one of his target balloons was not put in the right position, and he made impact, had major trauma, his lower extremities, and then had to operate his parachute under the most extreme conditions to be able to basically save his life. And it was opened very late in his descent, but it was enough to save his life, and he fell into some trees. So the shoulder is you know, prone to instability because of the expansive motions that we have there. 6 degrees of freedom, you know, ball and socket joint, moving socket with the scapula. So dynamic stability can be restored, but we really need to make sure we normalize passive and active mobility, and we work on neuromuscular control and preset. Now remember, preset is called feed forward. It's not feedback. Feedback can be used early in recovery, but feed forward and bringing the brain into the training is essential to maintaining dynamic shoulder stability. And then I'm of the opinion that once you've had an injury and you want to be athletically active, you should be performing maintenance activities for your shoulder from a neuromuscular perspective to make sure that you can maintain that stability. I don't think it's like we graduate from college and then we never have to study again, right? It's lifelong learning. And I think it's lifelong maintenance training as long as you want to be athletically active. And then we need to avoid bumper busters. In the knee, the bumpers are the menisci. In the shoulder, the bumpers are the labrum. Now, I'm from Spalding University in Louisville, Kentucky, and it's a small university. It's Division III NCAA sports. You've probably never heard of us before, but our gymnasium is actually the gymnasium where Cassius Clay learned how to box in a police boxing gym. And he was quite a talkative man and came up with many thoughts. And One of the things he said is it isn't the mountains ahead to climb that get you, wear you down, it's the pebble in your shoe. And I think there's a lot of truth to that. And I think there's a lot of truth to that in shoulder rehab too, because it's the little things we need to focus on. So how you prepare, how you train on a regular basis, this is highly important. And I like to say habits are like rabbits, they multiply. So you want, whether it's your student or your patient or your client, you want them to be developing the appropriate habits that will lead them to success, because bad habits will manifest themselves many times at the worst possible time. And sometimes, as I showed you with Jeb Corliss, it could lead to death. So we've seen an evolution in strength training. You know, 70s, 1960s, 1970s, a lot of bodybuilding type activities led by Arnold Schwarzenegger. And then later on in the 80s, we started seeing more cardio. Cardio came to the forefront, and step aerobics classes and things like that, and you know, different activities like Zumba. And then now we're seeing more activities like you see for CrossFit, other challenges where clients are putting their bodies through repetitious loads over and over again, which in limited amounts, in controlled volumes, they're not problematic, but in high volumes are problematic in terms of injury. They just wear down over time. And remember, the more functional the movement, the more responsibility the patient or client has to make sure that their technique is appropriate. And I think with high volume, one is more likely to drift into poor technique and sustain an injury. So looking at the shoulder joint proper, remember that Carter Rowe and others have talked about the relationship of the humeral head to the glenoid being like a golf ball on a tee or like a beach ball on the nose of a seal. We don't have a big osseous component to stability. So we have to remember that no matter what we do post-operatively or during return to place decision-making, that head needs to be maintained in proper position on the glenoid. It must be centrally positioned. This can be affected by movement of the arm, or it can be affected by movement proximally of the trunk and certainly of the scapula proper. So shoulder rehab is back rehab. Shoulder rehab is whole body rehab. Shoulder rehab is making sure that as the patient tries to do activities that are important to them, that humeral head remains well positioned on the glenoid. So, you know, we look at these wonderful textbooks that show us the beautiful descriptions of the rotator cuff and the biceps tendon and things like that. But it's important to note that when you go in and dissect these things anatomically, there's a lot of tissue blending. Some areas are what we call gray areas. You're not sure, is that tendon or is that muscle? Is that muscle or is that capsule? They really kind of blend into each other. And sometimes it's somewhat academic at the joint level to say that this is muscle or this is tendon. The important thing is that it's tissue and it needs to be at the appropriate length and the appropriate strength. So here we have a view with the arm removed. You're looking at it straight sagittal plane view, arm removed. You see the acromion, you see the biceps tendon, the long head of the biceps tendon right here, attaching to the superior labrum. And we have our anterior capsule, superior, middle, inferior. The inferior is like a hammock. It supports the head of the humerus so it doesn't translate inferiorly too far too fast. And then we have our rotator cuff back here coming over the top, and it goes underneath the acromion process. So remember, you know, that compression we can get from being under the acromion can be very problematic. And one of the first signs of a glenohumeral joint problem is to start having impingement type symptoms beneath the acromion process. So it's really key. I like to tell my clients that when you raise your arm, your shoulder should go down. I want to see that translation inferiorly, supported by the inferior glenohumeral ligaments as the arm is elevated in any plane of motion. So the other thing about those anterior capsular structures, superior, middle, and inferior glenohumeral joint ligaments, is they become progressively more taut as you elevate the arm, particularly in scaption or abduction. So the proprioceptive capability within the capsule and ligaments of the shoulder is better when the arm is away from the body, because the tension in the collagen activates the mechanoreceptors to provide position sense information. So if you think about it, the glenohumeral joint capsule ligament structures are better at providing position sense information when the arm is somewhat away from the body or range of motion. That's why the other agent that provides proprioceptive sense, the musculotendinous structures, are important also, because they provide more mid-range information. Now, if you think about the shoulder, the whole shoulder working together, the only place the appendicular skeleton makes contact to the axial skeleton from an osseous perspective is at the sternoclavicular joint. So other than that, this is really free moving. The scapula is free moving, held in place by connective tissue, fascia, ligaments, muscle, and the glenohumeral joint similarly. So you have this confluence of tendons from the arm, from the trunk, from the chest, from the neck, that all have an impact on where this upper quarter is positioned. And I think one of the most interesting areas is right here where I'm moving the cursor right now, the mouse. This is the coracoid process, where you have attachment from pectoralis minor, you have attachment from the short head of biceps brachii, and you have attachment from the coracobrachialis muscle. Three muscles, none of which are huge torque producers, make attachment to that, I think, for kinesthetic sense, for position sense property. And if you look at the coracoid, kind of like the center of maybe the axle of rotation, it really represents the front piece of the scapula. So as that scapula moves in 3 dimensions, those 3 little muscles provide important position sense information to the brain. So the other thing that's important to note is all your clients are not the same in terms of how flexible they are. And we need to look at this before we start training them or start rehabbing them, because if they show hypermobility, or what we call positive Bainton hypermobility signs, we might want to focus much more on mid-range stability. You have clients like this, you're not going to have difficulty getting their range of motion back. You should not feel particularly proud when you get their range of motion back. You should feel more proud when they don't have any episodes of instability, because these people are very loose, and you don't want them to focus too much on end range, extreme range of motion, both because the joint is loose, but also because their connective tissues in the capsule ligamentous structures are not as precise in providing their brain with position sense information. So even if I'm working with a shoulder, if I see this type of instability at the knee, at the elbow, at the fingers, at the thumb, that's a red flag for me. That tells me that I really want to focus on them working within mid ranges to become stronger and to develop neuromuscular control. Now, I mentioned about protecting your bumpers. Well, your bumpers are your labrum at the shoulder. So go back to your CrossFit people who are doing the same activities hundreds of times, if not thousands of times in a week. They are wearing down their bumpers, and this is a problem. The joint is the first, second, and third priority. The joint, the joint, the joint. And you know, with coaches and strength coaches in particular, they don't think about things that way. It's all about performance and muscle. But if you've destroyed your joint, it does not make any difference what your muscle status is, because you can't go anywhere. You don't have a good transmission. So you got to protect the bumpers, whether it's the shoulder like we're talking about today or the knee. So posture and acquired postures can be important too. And the glenoid, the position of the scapula, the socket of the shoulder, is going to be directly affected by the position of the torso. So low back posture, upper back posture, it's going to control where the scapula is in 3 dimensions. It's going to change the length relationships of many of the connective tissues, including the muscles. It's going to lead to impingement. If you have faulty posture and you go to elevate your arm, you're going to have impingement problems. This is what I like to say is a no-brainer. It's because the socket is not positioned in the right place. So we have to be cognizant of that. And in association with this, when you work with athletes or bodybuilders who like to say that, well, I do my chest and my back on Tuesdays, Thursdays, and I do my arms and my legs on, I don't know, Monday, Friday, split routine type thing. The important thing to note is that at the shoulder, they're spending all their time on internal rotation. So they're creating this imbalance where they're getting this internal rotated, protracted, downwardly rotated scapula. And this is feeding into shoulder pathology. We don't have, athletes do not spend enough time working on their upper back and particularly the muscles between the shoulder blades that help position the scapula appropriately on the trunk. So when you get a client from Dr. Wadi or another shoulder expert in India, I like to read the op note. I want to know what was done. I want to know if suture anchors were used, where they were positioned, how many were used. Obviously, if someone's got a bunch of suture anchors in their shoulder, they had a tremendous lesion. And you need to know about that. And when I rehab people, I don't really want the doctor to tell me exactly what to do. I want the doctor to tell me what I shouldn't do. You know, he's the only person, he or she are the only people that have actually seen that injury from the inside. And they say it looked good. I really felt good with that repair. You know, just go regular protocol. That's one thing. But if they look at it and they say, you know what, I'm still not really happy with the quality of that bone or how tight I could get that suture. I didn't want to make it over constrained. I didn't want to make it too tight. Just be careful when they start to elevate. These are important things I want to know as a treating physical therapist. So, you know, we've got force couples all around the shoulder. This is the transmission I talked about. I put in a picture of the transmission. And as you go to elevate your arm, you have relationships. You see the deltoid at the top of this slide. Well, the deltoid's the prime mover. You don't have any problem getting your athletes to train their deltoid. But unless you have a nice working relationship with the scapular muscles and a relationship with the infraspinatus in the back and the subscapularis in the front to provide a downward force on the humeral head, then deltoid function really doesn't matter. So you have to train the transmission muscles to be able to have performance from the prime mover muscles. And I alluded to this, I mentioned it just a second ago at the glenohumeral joint proper, but the glenohumeral joint is only going to be as effective as the position of the scapula. And we have similar force couples at the scapula with the upper trapezius, the serratus anterior, and very important, all those different components of the rhomboids, the lower trapezius, the middle trapezius. These are very important for maintaining appropriate scapular position and rotation as you go to elevate your arm. And if you have glenohumeral joint impingement, I'm sure you see this on a daily basis, you tend to see more activation of the upper trapezius. Well, the upper trapezius needs to be mitigated. It needs to be not used in isolation. It needs to be used in concert with the lower trapezius and the other scapular musculature like serratus anterior to make sure that the scapula is not moving too far too fast in substitution for glenohumeral joint function. So this is a slide I use with my knee talk as well, because this is really where I live when I work with people. You know, when we talk about proprioception, most of these measurements are somewhat academic, done in labs, like the picture on the left on this slide, where there's like an air cylinder put on the leg so the person doesn't get any cutaneous information. They're blindfolded and the machine moves their limb very slowly. And then they're trying to replicate the position that they started from, or they're trying to replicate a specific angle, and the person pushes that button to stop when they think they're at the appropriate angle. Well, this slow speed movement, this is very specific to joint capsule or ligament. What they've done is they've taken the skin out of the equation and they've taken muscle out of the equation and tendon. It's out of the equation because that functions when there's activation. This is non-contractile tissue they're testing here. So this is important, but it's not really where it's at in terms of what you can do as a therapist, because you're going to be spending more of your time working on the action side, the neuromuscular control side. More of the picture on the right where this is taking proprioception and changing it from a noun to a verb. This is putting it into action. And what can they do when they have to? How soon can they respond? Can they change direction very quickly? Can they activate their muscles in less than 0.2 of a second? Then, and only then, are they really developing the dynamic control needed to protect the joint. So the first part's important, you might do earlier in your rehab, but before you're making decisions about return to play, it's much more on the neuromuscular control side. So dynamic stability is essential. It's the state of having the joints in the right place at the right length. You have to have a complementary relationship between non-contractile and contractile components. And you know, more of our time early post-op, we probably spend more time working on positioning, appropriate length, appropriate range of motion, as we should. But ultimately, we translate the rehab more toward neuromuscular control and high-end function. So an Indian name, Punjabi, did some wonderful work talking about the trunk and talking about stability throughout the body, having both contractile elements, non-contractile elements, and then this overriding, bridging neuromuscular control element. Well, this is huge. If you look at the spine by itself, it only takes about 20 pounds of force to get it to collapse, to buckle, when you don't have activation of the muscles that run along the spine. So this is huge. Stuart McGill, a great researcher from Canada, has said that the spine and the trunk muscles function together like a fishing rod with supportive guide wires. So to me, it's scary in a sense, but it's also an opportunity for us as sports physiotherapists, because this is our environment. We can really have an impact on how we train these people for postural control, for dynamic joint stability, and dynamic shoulder stability. So there's the comments by Punjabi. And if you think about it, the somatosensory system, the muscular system, and the neuromuscular control system, these are directly trainable entities by us. But to optimize both of those two entities, the surgeon spends more time right on the non-contractile side, fixing things. But we spend more time on these things that require the brain: cognitive engagement, pre-plan, perception, things like that, spontaneity. We try to get it so things become more reflexive, more automatic actions, rather than, you know, when you first learn something new, you got to be thinking about it all the time. That's called executive function. You got to use more of your brain to get something simple done. But as you get better at it with training and you become a better athlete, so to speak, it's more automatic. When that ball comes at you, you're there. You get there quickly because you were already, it's almost like you knew where the ball was going before it got there. That level of training. And that's what you have to try to replicate in some of your rehab activities. So remember, we have the erector spinae, which is so important. It's important. We have different components: iliocostalis, longissimus, and spinalis. But we also have muscles that provide more proprioception, such as multifidus. We have important spinal stabilizers, quadratus lumborum, which, you know, we still don't have a good understanding of quadratus lumborum or serratus posterior. These are muscles that are part of the human body. They're no less important than many other muscles, but we still, at this point in 2020, don't have a firm understanding about their true contributions to posture and function. Certainly psoas and iliacus, you know, the hip flexors. One has iliacus has a direct component on the pelvis, and psoas comes from the transverse processes of the lumbar vertebrae. So when you're talking about a hip flexor, you're talking about a back muscle. You're not just talking about a hip muscle. We call it a hip flexor, but you know, it's got two ends. We got to know where it's coming from and where it's going. And then in cross section, if you look at about L3 in cross section, you know, with our, it's kind of a dynamic cylinder, an abdominal hoop. So we certainly have quite the strength contributions in 3 dimensions, particularly in the transverse plane from the oblique musculature. But now you can see quite clearly, look at this confluence of muscles back here. Psoas major, quadratus lumborum, and here's your erector spinae broken down into parts. And then here's transversus abdominis, which forms the inner ring of the abdominal hoop, which we'll learn is very important to activation of this whole system. But when you talk shoulder, you should be talking external obliques too. And this is one of the reasons why when you look at the pelvis, if you look at a skeleton, the top part of the ilium on both sides is wider, it's thicker. Why is that? Your students need to know that. The bone's not just, it's not wide, the bone is not naturally wide for no reason. It's wider in certain areas or has prominences in certain areas because something is pulling on it. Something is creating force through that. And in the case of the ilium, it's largely the external obliques. So here's an example of the Stuart McGill comment about the muscles providing support, like guide wires on a fishing pole. And, you know, look at this confluence. And the thing I haven't mentioned is thoracodorsal fascia. So if any of you are particularly interested in the world of fascia, which I'm becoming more and more interested in by the day, there's quite a system that influences what we call the posterior chain and how it transmits forces from the gluteus maximus on one side through the thoracodorsal fascia to the latissimus dorsi on the other side to the contralateral upper extremity. This system is so cool and it's so integrated. It's amazing. Here's another example. You know, when you suck your belly in for the photograph, you can kind of increase your stability. That's just hollowing. That's called hollowing. But another way to do it is to just let it stay out and just make the muscles tighter. That's called bracing. Because you still have the natural length relationship from the center of rotation, that is actually better for providing stability through the spine. So Hodges from Australia, some great research, talked about transversus abdominis. It's the first muscle activated. So when you go to raise your arm in any plane, whether you're standing or sitting, or maybe even supine, the first muscle that's activated is not your, your deltoid or your supraspinatus. It's your transversus abdominis. It's the stabilizing muscle of the base. So remember, we like to say proximal stability leads to improved distal mobility. And I like to think at the shoulder in particular that proximal stability also leads to improved distal stability, not just mobility. So it's important that we understand that the timing and the co-activation across these multiple segments have to occur in concert, in harmony. So if the transversus abdominis activation is delayed, then you're going to have inefficient dynamic spinal stabilization. And guess what? Because of that, you could have a shoulder problem, trying to bring it back to the purpose of the talk. So Stokes has talked about when we have this instability, we tend to use greater dependence on trunk muscle pre-activation. But when we pre-activate, particularly if we pre-activate and leave them on in co-activation for stability, that's very inefficient. Person's going to fatigue very fast. You can't have this co-activation on and then have it on all the time. You're just gonna, you can't continue like that. The key is to develop the capacity to turn things on and turn things off as needed in 3 dimensions with functional integration of the trunk and the upper extremity. And to be able to respond to sudden changes. What's a change? Well, this person comes down the hill on their bike. There's a lot of things that could happen in the next 10th of a second. They slip, the bike hits a piece of loose gravel. That's a perturbation. Something changed suddenly. Are they ready to respond to that in a safe manner? So activated muscles must serve as stabilizing springs rather than force generators, particularly through this abdominal hoop and this torso. So we have to develop this instantaneous dynamic spring-like stability, but it has to have the capacity to activate and to deactivate, turn on, turn off. It's like when you're preparing for a big match. If you think about it like a boiling kettle, you don't want to have it on boil. You just want to have it on boil when you need it for that split instant. Then you have to turn it down. And that's how we have to be able to activate our neuromuscular system too. Now, there's no single exercise that challenges all the muscles the best way. So I like Frank Noyes from Cincinnati, his rule of 3. Many things we do in therapy, the rule of 3 is a very good place to be. Whether it's 3 different functional tests or 3 different primary movements, 3 is something that I can remember most of the time. You get past that, I can't necessarily say that I can remember everything, and I know that my patients can't. So when you start defining home exercises, think about where you think the real value is, and then give them 3 things to work on. I would be hesitant to give them much more than that, because I think the expectation, no matter how, and this is, students do this all the time, they create these elegant plans that Einstein could not figure them out, you know, and I think many times the information maybe goes home with the patient, but it stays in the car. It doesn't get activated. But think about different maneuvers. Remember that the shoulder can be influenced by fatigue in the trunk muscles, so you have to have a certain sense of endurance. Any type of inflammatory process in the trunk, this can all be related to shoulder muscular dysfunction and atrophy. And I've already mentioned transversus abdominis. So an exercise that I use, and if you see my knee talk, I have this exercise in there too. You can change how the loads are, but is this matrix movement. I have a video coming up to see it in action. But the nice thing about this is I can provide slow speed, eccentric loading, as well as concentric, but slow speed eccentrics. And since the person moves in 3 dimensions and is always reaching, they're always trying to take up all the slack throughout their myofascial system as the trunk and the extremities move in concert with each other. The fascial tissue has a secondary tonic regulatory effect. There's some great papers out in the last maybe 5 years demonstrating the presence of myofibroblasts in fascial tissue. So your ability to stretch and use this fascial tissue in concert with primary muscle activation, I think, can have a hypertrophy effect on the muscles, in addition to just training straight muscle function in, you know, uniplanar motions. With these type of activities, we create instability slowly, and the patient learns how to mitigate that instability with dynamic activation. We start slow and move fast. Now here's the maneuver. This young lady is a basketball player. She's got a weighted vest on. I've added a fair amount of load to her, and she's about 8 or 10 inches off the ground. But this is an example kind of the basic movement path, and we can control the load. We can control the cadence. I'm a frustrated guitar player, so I have a metronome, and we can control, you know, how often that clicks. And when there's a click, there should be a maneuver. Something should be done. We can control the height. The duration is usually about 3 minutes, and we can put objects in the hands. It doesn't have to be a weighted medicine ball. It could be a tennis racket. It could be a pencil. It doesn't have to, the load is important, but the load isn't the primary thing. The primary thing is the arm position in relationship to the rest of the body. And then we can control the metabolic equivalence. So if I've used this exercise with my mother, whose birthday was yesterday, she turned 93. When she was in her 80s, she would do this exercise, not with a weighted jacket, not with a weighted medicine ball, but just in stepping and balancing and changing position. And I've also done it with, I've used this exercise with NFL football players with high loads. So you can adjust it to what you need based on the metabolic energy system, as well as the joint range of motion you're going for. And then of course, movement quality is much more important than how many sets or reps or how much total volume. So here's some examples, and this is my NFL player at the top doing some high-end things. He's probably got about 50 pounds in that vest. And then the bottom right, that's a quarterback using the boxing gloves, weighted gloves. So you can go with the floor, you can go with stable surfaces that are higher, or you can start introducing things like the Bosu ball or other unstable surfaces. But you're pretty much working whole body. Now, I would do this in concert with more isolated shoulder work. So you can see basically how everything's integrated here. So neuromuscular control, you know, training, I like you to think about it not so much from the muscle group perspective, but from the posture, the position perspective. And think about it like evolution. If you want to think about man evolving from primate form or evolving from quadruped to biped, think about how you can activate different musculature in the right sequence that's going to get you where you need to go to have optimal function. Now remember, the joints, like the glenohumeral joint or the knee joint, they're at risk for injury because they're getting farther away from the center of locomotion, you know, which is the core, you know, according to Grakovetsky, the core. And having worked Paralympic sports, I can see people ambulate with no legs. They ambulate quite well on their ischial tuberosities. So the center of locomotion is the core. And as we get farther away from that, it's harder to keep that synchrony. We can do it and we have to do it, but it's important to note that we need to train the trunk and the extremities to work together. So you can do that with various postures, various types of movements. Train movements, not muscles. Train movements, and the brain will work out which muscles need to activate. You train the movement, make sure they're in the right posture, and the muscle length will be appropriate too. So you can also take away vision. This is a baseball pitcher here. He's having difficulty. This is a therapist, Mike Reinhold, doing some tapping, early perturbation. Now, this would get some neuromuscular activation, but you could also use it more from the position sense standpoint we talked about earlier. Now, if you look at the individual on the bottom right here, you're in your event. Things happen. Do you think vision is good for this individual? Their center of mass is outside their base of support. They didn't know it was going to, be an ice storm this day. Things change, and you have to prepare your athlete for things that are within the realm of possibilities that could happen, and sometimes even outside the realm of possibilities of likelihood. Just because bad things can happen, and they need to be prepared. You don't want the first time they fall down or have an issue to be away from you. You want it to be with you so that you can help them. So we want to improve the impairments when we do things early, get range of motion back, and work toward functional integrity. We work from local to regional to global. Local meaning the glenohumeral joint proper, keep it well centered. Work on position sense, co-activation, rhythmic stabilization. We move toward overhead movements, making sure that the head of the humerus translates inferiorly as the arm moves up. And usually we begin in the sagittal plane, and then we get more toward the frontal and transverse plane with progression. But teach the patient to know what is a well-centered humeral head. We move from isometric to more concentric and eccentric exercises, relatively more adducted and internally rotated to more abducted and externally rotated, more static to more dynamic, and working more with the trunk to a greater whole extremity focus. We work from proximal to distal. And when I say proximal, as you can tell from my talk, I'm talking about even proximal to the scapula, to the trunk proper. There we go. So we have to be able to learn to turn things on and turn things off. We need to improve reflex responsiveness. And this is where the SAID principle comes into play, specific adaptations to impose demands. This young lady in this picture here, see if I can get back to my video. She's an exercise rider at Churchill Downs, our horse track. So she has to be able to, what's she gonna do when she falls off the horse? She has to learn that you roll. And I wanna see how she's a Bankart lesion repair, 5 suture anchors. So she's come a long way, and I want to make sure that when something bad happens, she knows how to manage that. And then falling, rolling, sliding, what's likely to happen? How many times do you have an elegant plan and then it all goes awry because the person fell down on the way to the game, or they stepped on a ball and sprained their ankle? You have to be prepared for bad things that could happen, and they have to know that they can recover from this. So you have to think ahead. And then this is some research I've done. I have one of my last papers on this pending. This is a machine that does whole body long axis rotation. And this is my NFL player. This gets resistance from compressed air, and you can actually manipulate the loading variables so that it can be purely eccentric, and the person has to hold position while it pushes them. So when I talk shoulder, I talk about positioning the humeral head, but I also talk about integrating the whole body. So you work from local to regional to global, reestablish normal range of motion. The joint, normal range of motion is the first, second, and third priority, normal tissue length. And then train them strength-wise from isometric through concentrics, progressively to the eccentrics that they're going to need for their sport. But heighten their neuromuscular responsiveness. I don't want them watching television when they do exercises with me. I want them to be having puzzles to solve. I want them to be thinking about how they're going to do this task, because you have to train the brain and the movement pattern. Then you can move into power. Power is just strength divided by time. So can they do this with high intensity very quickly? And can they do it over and over again? And then we reevaluate. There's no sin in having them come back. We say in surgery that nothing spoils good outcomes like long-term follow-up. But we need to follow up, and they need to be doing maintenance training, and we need to teach them to evaluate themselves so that they understand what's going on. So rehab pearls, first, second, and third priority, pain-free range of motion at the glenohumeral joint, train proximal stability, trunk and scapulothoracic joint, precedes glenohumeral joint mobility. Focus on strength training within mid-range, very important. And remember that the shoulder is a component of the entire kinetic or kinematic chain. So particularly early post-op, if they've had to immobilize for a length of time, work around it. Get the other segments. Make sure everything else is functioning optimally. Thank you very much.
Thank you, sir.
Yeah, thank you, John. That was an excellent insight in the dynamic shoulder stability and the related trunk fixation as well. So now we have got the basics clear from Professor John. We'll now move on to Yuvraj, who is going to tell us some tricks how to come over the stiffness of shoulder joint. Am I right, Yuvraj?
Yes, sir. Absolutely right.
Yeah. Okay. So before you start your presentation, I would like to give a brief introduction about Yuvraj to our other listeners. So Yuvraj has been one of the, I would say, young entrepreneurs in field of physiotherapy. He has been in the field of physiotherapy for last 13 years as a clinician, academician, and also a healthcare startup for a concern called Positive Physiotherapy. He has done his master's in musculoskeletal physiotherapy and also has a postgraduate diploma in healthcare management and clinical research. In addition to heading the sports physiotherapy at the MGM School of Physiotherapy, he has been associated with World Spine Care Clinic as well. His startup, Positive Physiotherapy, in addition to that, he is also a faculty for Strength and Conditioning Academy. So before Yuvraj, you start your presentation, I will request Dipti to give some instructions. Over to Dipti.
Thank you, sir. I would like to inform all the participants that there will be question answer session at the end of the webinar. And I request all of you to please put your video and audio on off mode. Thank you. Over to you, Raj sir.
Thank you, Dipti ma'am. Thank you, Vikas sir, for such a warm introduction. And I hope all of us are safe at home these troubled times. One thing which I feel this pandemic has given us is time, and time to brush up on basics, as we just had a wonderful to revisit all the basics was wonderful. Saturday had a wonderful session by Dr. Mihir Patel and Dr. Bhavna Matre, and it was so. As I see it, we have covered a lot of details about shoulder dysfunction. So I would like to keep my presentation more practically oriented, more clinically oriented. We also have a lot of clinicians, lot of students who are there for today's presentation. So the idea of creating this presentation was to keep it very, very simple, very, very practical, and show some nice exercises which they can start using immediately. Okay, so with that, I start my presentation. The topic was shoulder stiffness. So stiffness for us physiotherapists simply means reduced mobility or reduced range of motion. Now stiffness in broad terms could be of two types. It could be soft tissue stiffness or arthrogenic stiffness, or it could be a combination of both of them. Okay, arthrogenic stiffness consists can be of osteoarthritis, rheumatological, or it could be a malunion after a fracture. Soft tissue stiffness can result from myofascial issues. idiopathic frozen shoulder or secondary frozen shoulder. Now, we really or we are more concerned about the soft tissue causes of the stiffness, and that is where I want to keep my today's presentation on the soft tissue part of stiffness. And also within soft tissue part of stiffness, we can't cover everything at one go, so I want to keep it focused on what we call as idiopathic frozen shoulder or adhesive capsulitis. Okay, so let's just quickly go through what I mean by adhesive capsulitis. It's a term frozen shoulder was coined by Codman way back in 1934 as a condition of unknown etiology, and it just meant a painful and a stiff shoulder. Not much was known about the pathology back then. 1945, Nevassier called it adhesive capsulitis based on the observation of inflammation, fibrosis, and adhesions between the axillary folds of the capsule and the anatomic neck of humerus. Now, there has been a lot of research after that, a lot of confusions, a lot of different terminologies which have been used, but there are some people who now like to call it like a frozen shoulder contracture syndrome. We know now that it consists of pathologically there is thickening and contracture of the inferior glenohumeral joint capsule. The capsular volume gets reduced, and the coracohumeral ligament, which is on the anterior part of the shoulder, gets contracted. Okay, in fact, the contracture of the coracohumeral ligament is a distinguishing feature. If you compare the CHL on the affected and non-affected side, it will always be contracted on the affected side. And it is the contracture of the coracohumeral ligament which is a major restriction to your external rotation range of motion. Histologically, there is evidence of inflammation due to presence of fibroblasts. So it is now accepted that adhesive capsulitis is a combination of both inflammatory as well as a fibrotic process, and it is now believed that it is the inflammatory process which generally leads to the fibrotic process. Okay, so that is just about the nomenclature around frozen shoulder and capsulitis. Okay, in terms of characteristics, we know it generally affects people in their 50s, 40s and 50s, and it affects the non-dominant hand much more common than the dominant hand. Conditions such as diabetes, hypothyroidism, your obesity can be comorbidities predisposing you to adhesive capsulitis. The natural course of this disease is around a lot of research, but they say between 12 months to 36 months is the natural course. There is a time required to resolve this condition. Straight away come down to the diagnosis and treatment of this. Now, frozen shoulder is or adhesive capsulitis is a diagnosis which is mainly based clinically. There we look for pain, and pain which is experienced much more in the earliest phase rather than later phase. Pain which can disturb sleep. Pain can get aggravated when you sleep on the same side. And this pain can interfere with activities of daily living, such as reaching overhead or reaching the back pocket. There is, of course, restricted range of motion of AROM as active as well as passive range of motion. Now, of course, we popularly know that the passive range of motion is restricted more so in the capsular pattern, Syriac's classification, and external rotation more than abduction, more than internal rotation. Okay, so that is true, but of late, this has been challenged by a few people, and what we now know is that yes, in adhesive capsulitis, the movement most restricted would be external rotation. However, its restriction of abduction and internal rotation may vary from patient to patient. Many a times, frozen shoulder adhesive capsulitis is a diagnosis of exclusions. You have to rule out other causes of shoulder stiffness and pain, such as your rotator cuff tendinopathies, your, as Dr. John nicely explained, about shoulder instabilities, and of course your cervical referred pains. You can do a register isometric testing to rule out tendinopathies, and you can do a neurological scan or dermatomus myotis reflexes to look for any evidence of cervical referred pain. Yeah, in terms of treatment, the most important part of treatment is the education. Okay, so if a patient does come to the clinic, I would spend a majority of my time of the first session in explaining him the course of the disease. Is that this will take some time, maybe weeks, maybe months. You have to stay upbeat. You should not get frustrated. We have to manage your pain, and you have to get on a good home program for exercises. Get his expectations right. He should not be under a belief that this is going to get treated by in 10 sessions or 15 sessions, or if he increases the frequency of therapy, he's going to get more relief quicker. control of his diabetes, hypothyroidism, obesity will also go a very long way in controlling or in helping him recover from adhesive capsulitis. So education is very, very crucial even before we start doing any form of other form of modalities. For pain, two things can be done. As physiotherapists, we like to do joint mobilizations, and there is some evidence now that both types, that is low amplitude, even large amplitude joint mobilizations done over 12 weeks have shown some good improvement in shoulder function and in pain. So yes, that those can be done when the patients visit your clinic. They are pretty helpful maintenance mobilization. And of course, if the patient wants to self-manage his symptoms at home, yes, you can go ahead with taking heat or cold packs. Yes, it's very important that we explain him to manage his pain. He has to avoid those triggering movements, especially in the acute phase, and then we can go for more aggressive form of exercises. So for pain management, joint mobilization if he comes to the clinic, and heat and cold packs if he wants to self-manage himself at home. Okay. But today's discussion or today's presentation is more about the part 2, that is your what do you do for restricted active and passive range of motion. Okay. So for that, what exercises we do, let us just quickly look at what are the structures responsible for restricted range of motion. Here we see the shoulder from lateral view into 4 quadrants. So when we have a restriction of abduction with arm by side, generally it indicates that the things which are restricting the motion would be your coracohumeral ligament, as I explained earlier, your superior glenohumeral ligament, and the long head of biceps. When you find abduction, external rotation restricted in abducted position, the structures responsible for this could be the middle and the inferior glenohumeral ligaments. Okay, when you have internal rotation restricted with arm in neutral, that is your lift off kind of a position, or reaching the back pocket, it indicates your tightness of your superior glenohumeral joint capsule. And when you have internal rotation restricted in arm in abducted position, and generally indicates tightness of your axillary pouch of the capsule, the inferior glenohumeral ligament, and the labrum. Okay. Of course, so as we saw in the previous slide, we come back to the slide, is that the causes for restricted range of motion are multiple. It's your muscles, it's your capsule, it's your ligaments, it's your fascia, and they all as a whole will restrict your movement. Okay, so the exercises which we give, the therapy which we give, should be targeting each one of them individually and as a whole also. In terms of what kind of therapy is better, more and more meta-analysis are now showing that for treatment of stiffness due to adhesive capsulitis, it's better that the patients are on home self exercises, which are shown to be equally effective, if not superior to supervised exercises. That is to say that patients learn exercise from you, goes home, continues with exercise, and follow-ups with you on a infrequent kind of a basis. Okay, so stiffness, we were discussing stiffness, we were discussing about adhesive capsulitis, we discussed about possible structures responsible for tightness around the shoulder, and now we are know that it is more of the home program which is going to be effective in the long run. So let's look at what exercises can be given. Now, this is more of a experience, or I'm sharing more of my clinical experience rather than this is that these are the kind of exercises which I generally prefer to give to my patients with adhesive capsulitis. The warm-up, capsular stretches, activation and strength exercises, exercises to improving muscle length, thoracic mobility exercises, and functional exercises. Warm up, I like to include exercises which work on the fascia as a whole. Okay, here we have 2 exercises. I'll just play and then keep on talking. Yeah. So yeah, so fascia covers your everything. Fascia covers your muscle, your ligaments. It covers your joints. It covers everything. Okay, and if you want to learn more about fascia, one of the good books you can read would be Anatomy Trains by Tom Myers. And yeah, they describe facial lines around the shoulder. There are 4 facial lines which pass through the shoulder, and you have to, and your exercises should be targeting of improving the length of this facial lines. Okay. In terms of exercises, you can look up for one of the good resource for facial stretches. You can look up for something called the Great 8 Mobility Program. It's available on YouTube, and you can base your exercises on those kind, on what they are given there. There is a book also called Stretch to Win, which also gives nice exercises to work on the fascia around the shoulder. Okay, here I have shown you 2 exercises. The first one includes external rotation and different degrees of abduction. Of course, your patient might not be able to do it with such precision, but that's okay. Okay, this is a warm up and kind of facial stretches, and then she keeps on elevating the arm and keep on doing the rotations. The second exercise is a very nice and easy exercise, which we call as a TYI exercises. The patient opens up the arm, looks up, stretches the fascia on the anterior part of the shoulder. This is a T position, comes back to the neutral position. From here, they open up into a Y shape, and this is the, from here, holds for 5 seconds, comes back to the neutral position. And from here, the patient then will go into I position. Okay, so these are just a couple of warm-up exercises. Of course, you can look up for your own, you can design your own, but just an example of warm-up exercises which can be done, which will target the fascia around the shoulder and upper extremities. Okay. Capsule stretches, we all know, are very important. Okay, we have your posterior capsule stretch, which can be in standing position. Ensure where you're doing this, your scapula doesn't go into protraction. Okay, and you get a nice stretch on the posterior part of your GH joint where the posterior capsule is located. You hold the stretch for 30 seconds and repeat it around 3 to 4 times. We have your inferior capsule stretch. Okay, all must be doing. Take your arm as much as possible. Okay, again, ensure the scapula doesn't move excessively, and nicely stretch the GH joint, and you get a stretch on the inferior part of the GH joint. Okay. Now, yesterday on Saturday, Bhavana ma'am nicely explained about the importance of creating a balance between your local stabilizers and global mobilizers, and then working with them together. And same applies even to a patient with aggressive capsulitis, is that you have to, because of pain, there would be a kind of a shutdown of your local stabilizers. The local stabilizers are your small muscles which are very close to the joint axis. And for your GH, glenohumeral and the scapulothoracic joint, your local stabilizers are your some of your local stabilizers, subscapularis, your serratus anterior, middle, and lower trapezius. Just an example. So we start with precise activation exercises for your local stabilizers. Here just is an example of an exercise for activating your middle trapezius, which can be done in prone position, hands clasped behind your head, and you have to lift the elbow hardly by 1 inch, and you need to feel a tightening around your the middle region of the middle interscapular region. Don't overdo this movement. We don't want to recruit the levator scapular rhomboids while doing that. It's a very small movement, but we to recruit the middle trapezius. Okay. Similarly, you have to look for activation exercises of other muscles like serratus anterior and subscapularis. Now, once you have spent some time on the activation exercises, then you have to move on to more aggressive strength exercises, and you can use now weights, you can use TheraBand. You are now integrating your local stabilizers along with your mobilizers. Yeah, so one of the exercises which we like to do in the late stage would be something like a robbery exercise, which is done with TheraBand. This works on the rotator cuff muscles, it works on the scapular adductors. So this is one thing which we do. The point is here is that we start with activation exercises, and then you have to integrate the stabilizers and mobilizers together in a complex movements and exercises. Okay, I hope I'm clear till now. We move on to the next part, and that is your active stretches. That is when we said about creating a balance between your local stabilizer and global mobilizers. Your mobilizers are the muscles which have gone into activity, or we used to call them as tightness, Now these are big muscles away from the joint axis, and they are going into overactivity, trying to compensate for lack of activation of your local stabilizers. And these are a few exercises which we have listed down. Active stretches you have to for your overactive global mobilizers. Okay, so this is the active stretch for latissimus dorsi. It's a very big muscle, and it's a shoulder medial rotator. So if this muscle is overactive, you are going to have a lot of issues with arm elevation and glenohumeral external rotation. Okay, as you see, she's doing the exercise. Ensure while doing the exercises, don't arch your back or lift, or your chest should remain down. If you and the elbow remains extended and the hand is as close to the ear as possible. Okay, and hold this position for 15 counts. Bring it down. Repeat it 3 to 4 times. If done precisely, if done correctly, you will get a nice stretch over your inferior aspect of the glenohumeral and the region of the lat dorsi. Okay. One other reason which I feel I always prefer performing or teaching my patients active stretches rather than passive stretches is that when you do active stretches, you don't, it doesn't lead to excessive firing of your Golgi tendon organs. That is one thing which happens. And secondly, they are far better tolerated by your patients, even in the acute stage. These are better tolerated by the patient. Patient is in very good control of the movement and is much more comfortable performing. Okay, another, yeah. Next active stage we are discussing would be, would be for your rhomboids. And your rhomboids are your scapular adductors and scapular downward rotators, and generally to go into overactivity. And this is the position how you stretch out the rhomboids actively. This can be supine, it can be done in sitting or standing position also. What will happen if we don't work on rhomboids is that they would not allow scapular upward rotation, which is going to then interfere with your scapular upward rotation, and that is going to restrict any of your shoulder elevation kind of activities. Okay, now we go on to stretch for your rhomboids is done, and we go on to the stretch for your pectoralis major. Okay, and this is this exercise can be done in lying position. You open your hand in the position of T. Your pectoralis major is again your glenohumeral medial rotator. So, and it also has a component of anterior tipping. So if this muscle is in overactive, it is going to restrict you from going into external rotation. Okay, and another, as with other exercises, ensure your chest remains down, your ribs remain down, and you don't arch your back. Okay, and maintain the stretch for 15 counts and then repeat it 3 to 4 times. Okay, then there are other small muscles which you can work on, which are also kind of overactive, and you can work on the length of these muscles. These are your pectoralis minor, your levator scapulae, your anterior minor is very important because it is your scapular anterior tipper. If it remains overactive, it is going to not allow posterior tipping to happen, which is required during arm elevation. Pectoralis minor, if it tips the scapula anteriorly, it's also going to intrude into the subacromial space. It reduces the volume of subacromial space, which itself can lead to compression of structures leading to pain. So it's important to stretch pectoralis minor. Your levator scapulae is again your very strong shoulder downward rotator. So it needs to be released for you to get a good arm elevation and scapular upward rotation. Anterior scaleni again are very crucial because these muscles are they elevate your first rib and again reduce the space in the suprahumeral space. Okay, so that was about release of muscles. One other way you can release your muscles is something which we all physios know is myofascial release. Now, as we discussed, we don't really want patients to come to us frequently. So we want them to perform myofascial release, or we call it self-release at home. And just showing you a few examples of how you do it at home. This is about release of levator scapulae. You find a point on the superior angle of scapula. Keep a massage ball or keep a tennis ball over it. Okay, and just move your hand into abduction, cross body abduction. Yeah, this is your release for your levator scapulae. Then we have a release for your posterior capsule and your lateral rotators. You keep it on the area posterior to the GH joint, and you have to release, roll the ball front or back or up and down, and release the posterior capsule. Okay, and then you have to, again, in a similar way, you will work on the release of your pectoralis minor muscle. Keep the ball near your coracoid process. That is where the pectoralis minor gets inserted, little below it. And then there would be, generally there is a very bad trigger point there. Find that out and just roll it over gently for a minute or two. Okay. So to work on, we have to start with some good stretches. We have to start with activation exercises. They will progress into strength exercises. You have to work on active stretches of your mobilizers. You have to work, and patients can even perform self-release, self-MFR at home using a massage ball or a tennis ball. Okay, as Dr. John nicely mentioned, it's very important to work on your other parts of the kinematic chain also. So there comes the role of your thoracic mobility. Thoracic extension is very much required in having a normal shoulder function. Because if you don't have thoracic extension, you will not be able to get the end range of thoracic of the humeral flexion. Thoracic extension is required to give scapula the freedom to move into upward rotation. Okay, this is just an nice exercise which you can do in front of a chair or front of a stool. Okay, while doing this exercise, ensure you do not drop your head down. Think of elongating your spine rather than flexing your spine while doing the push your buttocks down, push your head straight. Okay, and think of elongating the spine, and you'll get a nice stretch in your mid thoracic region. Okay, hold for 10 to 15 counts and repeat it 3 times. Okay, thoracic rotations are very crucial in this. We could work in various positions, but I would prefer it to work in all 4 positions. One advantage which happens here is that along with working on the mobility of the thoracic spine, you are also working, creating a closed chain for the supported hand, and you are working on the scapular stabilizers also. So this is a nice exercise to work on thoracic rotation. Okay, man, in the end, it has to be functional important. Now, there is no ready-made recipe for which is a good functional exercise. For a cricket fast bowler, a functional exercise would be something which has to take the arm into abduction and external rotation, and that would be a very good position to do his functional exercises. But for normal people, for those who are a little bit more conservative, you can use the traditional Indian exercises of yogasanas. They are beautiful exercises. They include multiple joints, they include multiple muscles. You are working on the entire kinetic chain when you are doing these exercises. So yeah, one exercise which I again prefer in this is the Bhujanga. It nicely, it works on the stretching of the anterior structures. It works on the extensibility of your thoracic spine, and it also works on the stability of the scapulothoracic joint. So yeah, very popular exercise which we all are aware of. Okay, which is Bhujangasana, which can be done. Okay, there are new exercises which has come up, and one of them which has impressed me quite a lot in the last few months would be something like animal flow exercises. Here, these are ground-based exercises where you mimic the positions or poses of different animals. There is a scorpion, there is a crab, there is a beast. Okay, the good thing is that they work on stability and mobility at the same time. So, for example, if I'm doing scorpion reach, as I'm working on the extensibility of my lat dorsi, of my posterior chain, I'm also at the same time, there is going to be a lot of stability required at the glenohumeral and the scapulothoracic joint. So they nicely work on the stability and mobility part of your demands. Okay. Okay. So yeah. So in summary, it's not like you have to do only these exercises. The aim here was to give us some kind of structure, to what kind of exercises could be very good home exercises program. You could explore yourself, which would be good exercises, read from different sources, and then you can make your own exercises. Okay. What I like to do typically in my clinic would be to start, of course, with educating the patient first to set his expectations right, as we discussed. Then we start with exercise for your glenohumeral and scapulothoracic joint, release of your overactive muscles using your active stretch releases. This is the initial few weeks of the treatment where the patient generally visits me once in a week, if not lesser. Okay, then it progresses to progressive strengthening of your stabilizers and mobilizers, integrating them together. Then we start making it slightly more challenging in terms of extensibility. We start doing thoracic mobility exercises and other advanced form of stretches. And finally, it all has to culminate into your functional exercises. Okay, as we discussed, you can use yogasanas, you can use other body weight exercises, ground exercises, which can be done. Generally, your sports patients are someone who like to visit you much more often in this space, because this is the time they want to return to sport. So that is the thing. But for a normal person, this is a time when they would better off on doing the exercises at home by themselves, and they can just follow up with you once in a while just to check how they are doing. Okay, fair enough. So that was about it. I think I hope I was able to keep it simple, and I hope you got to see some nice exercises. Thank you so much. Over to you, Vikas.
Thank you, Dr. Yuvraj. An excellent presentation. Gave me good insight in what even I could do to my patients. So thanks a lot. And over to Deepti for now question answer sessions.
Thank you, sir. Thank you, both of you. It was a very enlightening lecture. There are few questions for both of you, and we will.
Ma'am, I am not able to hear you very clearly.
Hello.
Yes, ma'am.
Can you hear me?
That's better.
Yeah.
Yeah.
Okay. We will start first with the John sir. Okay. The first question is for you. What is your experience with the shoulder arthroplasty in getting back range of motion and function?
My personal experience is very limited with arthroplasty. It's mostly with
Yes.
arthroscopy. I do know, remember when they do a total shoulder or a reverse total shoulder, it's because the rotator cuff is basically destroyed. So the prosthesis now replaces the rotator cuff in terms of function predominantly, and the deltoid works over the prosthesis. So my experiences in that area are limited. I'd be hesitant to comment too much.
Okay, sir. We don't. For you, transverse abdominis in sports person.
Well, you know, the key is the movement pattern, and I want to compliment Yuvraj on his talk. That was a wonderful talk. And, you know, transversus abdominis, when you first teach them about activating that, you usually have them on the table in a hook lying or hook position, so their knees are flexed, and they're learning how to posterior pelvic tilt, and they're learning how to activate transversus abdominis. The key thing for a sports person now is you got to translate that function from being supine on a table to being in different positions, including sitting and half kneeling and standing and in an athletic ready position. So the teaching is the same, but the translation and the expectation is much higher. So, you know, if they cannot activate that and position their pelvis accordingly, they're not ready to progress. So the big thing with a sports person is the expectations and demands are going to be much greater.
Okay, sir. Thank you. Sir, third question is for you. When to progress from concentric to eccentric type of exercises in training?
This for me also?
Yes, sir.
Okay. You know, the textbooks would tell you that you do isometrics first, and then you do concentrics, and then you do eccentrics. And we know that tissue is going to heal pretty good by 6 weeks. But with good fixation, we can start blending things much earlier. Just because you're doing eccentrics, it doesn't have to be high load eccentrics. It can be progressive light load eccentrics. Paul Listeo at University of Utah has written many papers on lower extremity for progressive eccentrics that are done quite early. So I think the most important thing is to know what are the motions that are going to most likely cause instability, and maybe spend a little bit more time with isometrics with those motions. But where the motions are unlikely to cause instability, I think you could be a little bit progressive earlier. Certainly before 6 weeks, you could start doing some concentric progressive training. And with that, you could do some light eccentrics. So, you know, I don't want to sound like I'm hedging, but basing when we can start certain exercises on time post-surgery is a somewhat primitive way of looking at it. The main thing is avoiding further trauma, further injury, what motions need to be avoided, and where you can, hey, be more progressive with it, and also work at adjacent joints with strength training, and also work on the contralateral side. There's benefit. And that's one of the things with my program. I always work both sides. I don't just focus on the surgical side.
Okay, sir. Thank you, sir. Sir, there's a next question for you. Role of subscapularis in restoring dynamic shoulder stability.
Subscapularis, you know, we train it many times in standing. I liked Yuvraj's foot position too. That's very important to put people in a position of function, even when they're doing adducted internal and external rotation. This is a full body exercise, and I liked how he had a foot forward with that. That's real important. You know, and when we train it at that level, we train the subscapularis early, we train it as an internal rotator. But in function, it functions in synergy with infraspinatus to inferiorly translate the head of the humerus safely and help with external rotation. The infraspinatus helps with external rotation as we elevate the arm. So to train that, you're best served having people work on early three-dimensional sagittal plane, frontal plane, shoulder scaption, shoulder movement patterns, but while keeping their shoulder down as their arm comes up. With that, you'll have inferior glide of the head of the humerus on the glenoid, and you will show that subscapularis and infraspinatus are working together.
Okay.
See, we learn things in isolation,
Right.
but on the functional side, everything's integrated. So we have to make the transition from trying to isolate a particular muscle group during acute care to really making sure that it's moving and acting the way it needs to when it functions. So I think the more comfortable you are knowing that subscapularis is activating when you do your internal rotation exercises with TheraBand or something, the more confident you should be that the patient's also ready to begin elevation, where the subscapularis is going to work in harmony with infraspinatus to control inferior glide of the head of the humerus.
Yes. Okay, sir. Thank you, sir. Sir, there is 2 questions for you. How to identify trunk muscles are reason for impaired shoulder instability?
I think, you know, obviously after surgery, you're going to spend more time focusing local on the shoulder. But I think the reason for most failures are not at the shoulder, they're at other adjacent areas in the kinematic chain. So my point is, if you have dysfunction or inhibition in the trunk muscles, you're going to have a poorly positioned scapula. If you have a poorly positioned scapula, you're going to have a dysfunctional glenohumeral joint. It may present itself as rotator cuff inhibition. It may present itself as trigger points like Yuvraj mentioned so nicely with you know, working on the posterior capsule and things like that. So I think as you transition away from acute care and you start thinking about, can I do some concentrics? Can I do some eccentrics? Also think about how adjacent joints are working, including the trunk. And if you do that, I think you're less likely to have further injury. So and the other thing about the trunk, let's suppose Dr. Wadi did surgery on someone and you get them the day after surgery. Maybe there's only a few things you can do with that person's shoulder. Maybe they can start doing Codman's pendulum exercises or something like that.
Yes.
But he hasn't done any surgery on their trunk.
Right.
So you can start being more aggressive with scapulothoracic exercises and with trunk exercises early, making sure your patient has normal range of motion first. Remember, that's our first priority. Like Yuvraj showed elegantly, opening and closing the thoracic spine from a quadruped position, and then the functional movements, the scorpion and such. Now, obviously you wouldn't do that early, but you could certainly do a lot of torso movements early to make sure that that system is functioning optimally. The shoulder is like a whip. It's like a whip. And the shoulder itself is sort of weak. Those muscles and tendons around there are sort of weak. So you want to optimize the whole system so that things work together. And if you're taking something away early because you can't do range of motion because it's an acute care repair, you have to give them something back. And the thing you give them back is to optimize the motions and strength and stability throughout the rest of the kinematic chain. So I begin with the trunk.
Okay, sir. So that means actually the trunk stability exercise, it should be basically the part of the pre-rehabilitation also. We should start with the pre-rehabilitation.
Absolutely.
Yes,
Absolutely.
sir. Okay, sir. Thank you, sir. Now over to you, Raj. There are a few questions for you. Role of close chain exercises in stiff shoulder.
Yeah, they are very important, as we discussed in the initial stage itself.
Right.
We want to work on the activation of scapulothoracic and humeral stabilizers, and close chain exercises are a wonderful way of doing this kind of thing. Okay, so you can do a lot of activation exercises for your serratus anterior, for your rotator cuff in all four positions. So if they're tolerated well, the irritability of tissues is not that bad. Yes, they should definitely be used even in the early stage of rehabilitation. That way.
Okay. Yeah, there is one more question. There is one question for you. Is 30-second stretch is sufficient for to improve flexibility of capsule?
Actually, honestly, I don't know the answer to this question. Let me just accept that. Okay, we all like to believe it is 30 seconds, but maybe somebody else far more can put a light on that. That will be great.
Sir, so John, sir, what is your opinion about this?
What was the question again?
Is 30-second stretch is enough to improve the flexibility of the capsule?
I like longer. I like low. I mean, 30 seconds is plenty long, but I generally err on the side of going too long because a lot of clients are going to go too fast. I go too long and low intensity and proper position. So I think 30 seconds is good. And I like 2 or 3 repetitions of a given stretch. And I like them to do it maybe a couple times a day. And normally I don't just give them a lot of stretches to do, but I might pick 1 stretch or 2 that I think is going to give me the most benefit. I try to identify the primary problem area and teach the client, the patient, to do it correctly, maybe 1 or 2 different stretches.
Okay, sir. Thank you, sir. There's a question for you, Raj.
Yes.
Yeah. In painful shoulder, how stretching will help? If the shoulder is painful, then how stretching will help?
No. So if you saw that the last thing which we said, we want to work on stretching in the earlier phase. Okay, in the earlier phase, we have to work on education, self-managing the pain, and work on activation of muscles. And you can start with, as we discussed, something called active stretches. Here the advantage is that the patient would not go into the pain zone because he is in control of his exercise. That's the thing. And yes, once the patient settles down, I think it's very important then to be a bit more aggressive and go for stretching the interkinetic chain. So acute stage, no. Acute stage, or I would say when the tissues are irritable, we don't want really we don't want to stretch them excessively. But once we go into the less irritable structures, then the structures get settled down, then we definitely want to stretch them, and not just the muscles, but the entire kinematic chain also we want to stretch the entire, like let's say if you're doing the posterior chain, we want to stretch it entirely.
Okay, thank you. There's one question to you. Role of mobilization techniques in the frozen shoulder.
Yeah. Okay, so when I was making this, I looked it up quite a lot about the role of mobilization, and see, the thing is, it's more of the soft tissues which are getting affected primarily. It is your the capsule, the ligaments which are getting affected. The fascia will get affected, and because of pain, and there is going to be a lot of imbalance of muscle. So it's more of the soft tissues which is the primary thing. Still, there was a 2015 study which says that low amplitude mobilization and even large amplitude mobilization done for something like twice in a week for a period of 12 weeks has shown significant improvement. So yeah, so that is your answer, is that yes, if you have patient coming down to the clinic, manual therapy or maintenance mobilization can be attempted. So that's up to you.
Okay. Yuvraj, there is one more question for you. Could you please guide the strengthening exercises in restricted range of motion?
Yeah.
When ranges are restricted, how we will go for the strengthening?
Yeah, so I completely agree to that point that for something like middle trapezius activation might not be possible in the early phase. But that is where you can do more of your activation of other muscles which are there, and the various positions. For example, you could still work on subscapularis, you can work on serratus anterior, and you can still find different positions to activate your trapezius muscle. Followed by, and once that is possible, I think weight bearing positions are wonderful way to work in the initial stage, because that is where you don't need to go into the extreme ranges when you are in all positions. You can start with those, and once the pain starts settling and once you start getting the mobility, you can then start exploring your TheraBand and other form of exercises.
Yeah, thank you. There is one question for you. The question is, any other way of working on improving range of motion, especially abduction and external rotation apart from mobilization?
Apart from mobilization, okay, so they're not evidence based, but you could definitely try movement with mobilization. This I will definitely do clinically. If that helps, it's kind of what we like to call as a load modification kind of a procedure, where if that setting the head posteriorly is helping you improve the range of motion, that can be integrated into exercise using a band, and that can be done. So yeah, you can explore something like you can try a load modification of pushing the humeral head posteriorly, inferiorly, and rechecking the abduction range. If that works, you can use a belt to hold the shoulder in that position, and the patient does active exercises. Yeah, so that is one other way you can do apart from what I just.
Okay. Now it is the last question for both of you. Role of ultrasound in adhesive capsulitis, mainly for Yuvraj.
Okay. I don't think there is much role of ultrasound in adhesive capsulitis. People clinically in India, we still use it in clinical setup. I should absolutely accept that. This is when patients themselves demand, we want ultrasound, we want to come more often. So it can be used, but there is no evidence which supports use of ultrasound in adhesive capsulitis.
What is your opinion on this, Johnson?
In my experience, it's quite a time. We tried physio several times before we would make a decision that they needed to have arthroscopy. In fact, sometimes they'll get manipulated under anesthesia without arthroscopy. If there's no evidence of intra-articular pathology other than tightness in the joint capsule or bursitis, sometimes we'll just treat them with manipulation under anesthesia. I've actually done the manipulations under anesthesia. And as a physio, it's really enlightening, because obviously the patient's unconscious, so you're very careful, and you've moved them in the clinic, you know how they feel. But when they are unconscious, it's just connective tissue. It's not musculotendinous tissue that's resisting you. And it makes a sound almost like a celery. If you take celery and crunch the celery, you start to get the adhesions breaking. And it, as a physio, it's very rewarding to know that you're not hurting them and you're actually getting this tissue to break these adhesions and you get their normal range of motion. But I think the key is after they do this, that they see it and they know that they've been there, and maybe you show them some video. And this is where, if you're going to do it, rather than a general anesthesia, maybe like a block, a block, so they're actually conscious during the manipulation. So they can actually see their arm moving. They don't feel the pain, but they see it moving. And then you follow it up with active exercises the same day.
Yes, sir. Thank you, sir. We have just received one question on YouTube. We'll take this question. This is the last question for today's session. And this question is for both of you. How long would one wait before going for the arthroscopic release in frozen shoulder? Can we start with John, sir?
I really thought that was the question I was answering before.
Yes, yes, right. Yeah, already
Yeah.
answered. Yes. Yeah.
Yeah, we would do physio a lot. We would have to really fail physio. We might, if we weren't getting success, we might try a different physical therapist. But we would wait a long time before going to arthroscopy for something like that, unless there was defined intra-articular pathology.
Okay, sir.
Can I ask one question to both of you?
Yes,
Yes,
sir.
sir.
Yeah, what do you think is the role of hydrocort injection in this? Is there any role for this? We have been, I have seen many orthopedic surgeons using that, one of the ways of treating frozen shoulder. So what's your experience, both of you, Professor John and Dr. Yuvraj? So Dr. John first, please.
I have not seen this used in practice.
Oh, okay. Okay, Yuvraj?
Sir, honestly, I don't have enough knowledge to answer this question, but people do use it clinically, and yeah, we have seen some good effects with them also. It's not like it's some absolutely wrong or
No,
something.
I would like to know is, Yuvraj, have you seen any patients? Those who have gone to an orthopedic surgeon, taken hydrocort shot, and then come to you. So my question is, with the kind of physiotherapy what you do, and a patient who has come with you to you with hydrocort shot, do you see any difference from your point of view when you start your physiotherapy with these two sets of patients?
Yeah, because sir, I will answer this slightly differently. What I have seen clinically is that a case where a patient comes to us after 3 weeks, gets frustrated because he doesn't get the results as he wants. This is the ortho, and they undergo hydrocort injection, and after that there is this tendency of again immobilizing him for a period of 2 to 3 weeks, or if not more, and then they revisit and they come back to us. And I feel if we are able to create the right expectations, as I said, if we are able to educate the patient nicely that this is going to take time, and research shows that the results from supervised home program, or be it aggressive therapy or any aggressive treatment, not just physiotherapy, is almost the same in the long term. You should wait. That is the better way of going it. What I feel personally is if they go for hydrocort, I lose time. For at least year where I practice, after hydrocort, they would be told to not exercise for a period of a few weeks. So I feel you again lose time, and when they come back, generally they are almost the same. And the pain does get better, but the range is almost the same when they come back.
Right. Okay. Thank you, Yuvraj. Thank you.
Thank you, sir.
Yeah.
Thank you, both of you. Okay.
Thank you.
Yeah. Okay. Vikas, sir, continue. Yeah.
Yeah. So thank you, both of you. We had an excellent session. Last 2 hours, we have been listening to you two guys. A lot of insight. I could brush up my anatomy once again after so many years. So that was pretty good. And the outlook you are given to us is the best, I could say. And I'm thankful for that we will be able to help us patient much more in this way. So thanks a lot. We look forward to seeing you once again some other time.
Thank you very much.
Thank you so much, sir.
Thank you both of you for such a wonderful session. Okay, now we are ending the session here. I just wanted to I would like to thanks to our entire team, Dr. Maria Jayandani ma'am, Josna Thosar ma'am, Ravindran sir, Mayur sir, and also the Arthroscopic Academy, Dr. Roshan Wade sir and Sandeep sir. Okay, our next webinar is on the 28th May. Topics are rotator cuff injury, what and how of the surgical management by Dr. Abhishek Nerurkar, and physiotherapy for rotator cuff involvement by Dr. Ajit Dabholkar. Thank you all of you once again. Thank you very much.
Thank you.
Thank you so much. Bye.
Thank you, John. Is Ajita there? Ravindra?